What are the key components of a comprehensive pelvic examination, and why is each component clinically significant? Answer: a comprehensive pelvic examination consists of several key components. History taking, understanding the patient's menstrual history, sexual history, and any relevant medical or surgical history is critical. It guides the examination process and helps identify areas of concern. External inspection, observing the external genitalia for any abnormalities such as lesions, swelling, or signs of infection is important for initial assessment. Speculum examination. This allows for visualization of the vaginal walls and cervix. It is essential for obtaining Pap smears and screening for cervical cancer. Bimanual examination. Assessing the size, shape, and position of the uterus and ovaries through this method can help identify structural abnormalities such as fibroids or ovarian cysts. Rectovaginal examination, if indicated. This can provide additional information regarding pelvic masses and the posterior cul-de-sac. The significance of each component lies in the ability to detect abnormalities early, provide preventive care, and address patient concerns effectively. Mr. Smith is a 29-year-old man who presents with a sexual history of multiple partners and a recent episode of urethral discharge. What screening protocol should his healthcare provider follow for sexually transmitted infections, STIs, and what counseling should be provided? Answer: in this scenario, Mr. Smith should be screened for STs using the following protocols. Gonorrhea and chlamydia testing. Given his symptoms and history, both should be tested via nucleic acid amplification tests, NOTS, ideally using a first catch urine sample. HIV testing. Routine HIV testing is recommended for sexually active individuals. A rapid test can be conducted on site with follow-up testing if positive. Syphilis testing. A serologic test for syphilis should also be included, given the risk factors associated with multiple partners. Hepatitis screening, depending on risk factors. Men who have sex with men, hepatitis A and B vaccinations should be offered, and serologic testing for hepatitis should be considered. Counseling should include discussions about safe sex practices. Condom use, the importance of notifying sexual partners about potential exposure and the availability of pre-exposure prophylaxis PrEP for HIV prevention. What are the differences between primary and secondary dysmenorrhea in terms of etiology, clinical presentation, and treatment options? Answer: primary dysmenorrhea, etiology, caused by increased prostaglandin production leading to uterine contractions. Clinical presentation typically occurs in young women characterized by crampy lower abdominal pain beginning just before or at the onset of menstruation, often accompanied by nausea, vomiting, and diarrhea. Treatment options. First-line treatments include NSAIDs, ibuprofen, naproxen to reduce prostaglandin production, hormonal therapies, combined oral contraceptives may be utilized to regulate cycles and decrease pain. Secondary dysmenorrhea, etiology, results from underlying gynecological conditions such as endometriosis, uterine fibroids, or pelvic inflammatory disease. Clinical presentation, often presents later in life with pain that may start before menstruation and persist throughout the menstrual period. Pain may be associated with other symptoms specific to the underlying condition. Treatment options. Management focuses on treating the underlying condition, which may involve hormonal therapies or surgical interventions in severe cases. Describe the diagnostic criteria for polycystic ovarian syndrome, PCOS, and discuss the potential long-term health implications associated with this condition. Answer: the diagnostic criteria for PCOS, commonly based on the Rotterdam criteria, require the presence of at least two of the following three features: oligo or anovulation, irregular or absent menstrual cycles indicative of ovulatory dysfunction, clinical and or biochemical signs of hyperandrogenism. Symptoms may include hirsutism, acne, and alopecia. Biochemical evidence includes elevated testosterone levels. Polycystic ovaries, identified via ultrasound, showing the presence of 12 or more follicles in each ovary measuring 9 mm in diameter, or increased ovarian volume, 10 ml. Long-term health implications of PCOS include increased risks for type 2 diabetes, hypertension, endometrial hyperplasia and cancer, dyslipidemia, and cardiovascular disease. Managing PCOS involves lifestyle interventions, hormonal regulation, and monitoring for these associated conditions. In a context of abnormal uterine bleeding, or explain the significance of classifying AUB into structural and non-structural categories and outline the diagnostic workup for each. Answer: classifying AUB into structural and non-structural categories is crucial for determining the appropriate diagnostic and management strategies. Structural ORB includes identifiable lesions such as polyps, fibroids, adenomyosis, and malignancy. Diagnosis may involve pelvic ultrasound to assess for fibroids or polyps. Hysteroscopy allows for direct visualization and potential biopsy of the endometrial cavity. Endometrial biopsy to rule out endometrial hyperplasia or cancer, especially in women over 45 or those with risk factors. Non-structural ORB includes conditions such as coagulopathy, ovulatory dysfunction, or hormonal imbalance. The diagnostic workup may include thyroid function tests to evaluate for thyroid disorders, coagulation profile, especially in patients with a history of bleeding disorders, hormonal testing to assess for conditions like PCOS or hyperprolactinemia. Explain the interpretation of Pap smear results, specifically focusing on the terms ASCUS, LSIL, and HSIL, and outline the management strategies for each category. Answer: Pap smear results are categorized based on the level of cervical dysplasia. ASCUS, atypical, squamous cells of undetermined significance. Interpretation: this finding suggests the presence of abnormal cells but does not clearly indicate the presence of a high-grade lesion. Management: repeat Pap smear in 12 months or perform HPV testing. If HPV positive, a colposcopy should be considered. LSIL, low-grade squamous intraepithelial lesion. Interpretation: typically associated with mild dysplasia and HPV infection. Management: most LSIL lesions regress spontaneously. However, a colposcopy is recommended to evaluate for high-grade lesions. HSIL, high-grade squamous intraepithelial lesion. Interpretation: indicates a higher risk for cervical cancer and suggests significant dysplasia. Management: immediate colposcopy with biopsy is indicated to evaluate the extent of the lesion and determine further management, which may include excisional procedures, e.g. LEP or conization. A 22-year-old female presents with primary amenorrhea and has not developed secondary sexual characteristics. She is concerned about her fertility. Discuss the evaluation process for primary amenorrhea and the potential underlying causes that should be considered. Answer: the evaluation of primary amenorrhea involves a thorough history and physical examination, followed by targeted diagnostic tests. History: assess for family history of amenorrhea, any signs of sexual development, weight changes, exercise history, and medical history, including chronic illnesses. Physical examination: evaluate for signs of hyperandrogenism, e.g. hirsutism, acne, and check for development of secondary sexual characteristics, breast development, pubic hair. Laboratory tests: pregnancy test to rule out pregnancy as the cause. Hormonal assessment: measure serum FSH/LH, estrogen, prolactin, and TSH levels to evaluate ovarian function and rule out thyroid or pituitary disorders. Imaging studies: an ultrasound may be performed to assess uterine and ovarian anatomy. An MRI may be indicated if pituitary disorders are suspected. Potential underlying causes include hypogonadotropic hypogonadism. Low FSH and LH levels could indicate hypothalamic or pituitary dysfunction. Hypogonadotropic hypogonadism. High FSH and LH levels indicate ovarian insufficiency or failure. Congenital anomalies, such as mononeogenesis, which affects uterine development. Androgen insensitivity syndrome, in XY individuals presenting as primary amenorrhea without secondary sexual characteristics. The evaluation process is critical for determining potential fertility and appropriate management options. Discuss the role of hormonal therapies in managing dysmenorrhea and the mechanisms through which they alleviate symptoms. Answer: hormonal therapies play a significant role in managing dysmenorrhea, particularly primary dysmenorrhea, by addressing the underlying hormonal imbalances and reducing prostaglandin production. Combined oral contraceptives, COX, mechanism: COCS suppress ovulation and reduce the thickness of the endometrial lining, thereby decreasing menstrual flow and the associated production of prostaglandins. This can lead to reduced cramping and overall menstrual pain. Progestins, mechanism: progestins can also help regulate menstrual cycles and reduce menstrual flow. They may be used alone or in conjunction with estrogens in contraceptive methods. Levonorgestrel-releasing intrauterine system (IS). Mechanism: this device releases progestin locally within the uterus, thinning the endometrial lining and significantly reducing menstrual bleeding and dysmenorrhea. A 35-year-old woman is diagnosed with abnormal uterine bleeding and is found to have uterine fibroids. What management options are available and what factors should be considered when determining the appropriate treatment strategy? Answer: management options for uterine fibroids in the context of IUB include observation. If the fibroids are small and asymptomatic, monitoring may be appropriate, especially in perimenopausal women. Medications, NSAIDs for pain management, hormonal treatments such as COCS or progestins to regulate menstrual cycles and control bleeding, or agonists. These can shrink fibroids temporarily, making them useful for preoperative management. Minimally invasive procedures, uterine artery embolization (UE) reduces blood flow to the fibroids, leading to their shrinkage and alleviating symptoms. Myomectomy, surgical removal of fibroids while preserving the uterus, suitable for women desiring future fertility. Hysterectomy, considered for women with significant symptoms or those who do not wish to preserve fertility. This is the definitive treatment for fibroids. Factors influencing the treatment strategy include the patient's age, desire for future fertility, the size and location of the fibroids, symptom severity, and overall health. A multidisciplinary approach involving gynecologists and, when necessary, interventional radiologists may be beneficial for optimal management. Explain the implications of STI screening in gynecological care and the rationale behind the current guidelines for specific populations. Answer: STI screening is a crucial component of routine gynecological care due to its implications for both individual and public health. Current guidelines recommend routine screening based on various factors, including age, sexual history, and risk behaviors. Chlamydia and gonorrhea. Guidelines. The U.S. Preventive Services Task Force recommends annual screening for sexually active women under 25 and those at higher risk, such as individuals with multiple sexual partners or a history of STIs. Rationale: early detection and treatment reduce the risk of complications such as pelvic inflammatory disease, infertility, and ectopic pregnancy. HIV screening. Guidelines. Routine screening for individuals aged 15 to 65, with more frequent testing for high-risk populations. Rationale: early identification of HIV allows for timely initiation of antiretroviral therapy, significantly reducing morbidity and preventing transmission. Syphilis screening. Guidelines. Recommended for high-risk groups, including men who have sex with men and individuals with a history of substance abuse. Rationale: syphilis can lead to serious health complications if untreated, and early detection is critical for effective management. The implications of STI screening extend beyond individual health. They play a vital role in controlling the spread of infections and improving overall community health outcomes. Educating patients on the importance of regular screening and safe sexual practices is essential for effective STI prevention. A non-stress test, NST, is performed on a pregnant patient at 32 weeks gestation. The test results show no accelerations in the fetal heart rate over a 20-minute period. What are the possible interpretations of these results, and what subsequent actions should the healthcare provider consider? Answer: the NST is a key assessment tool for fetal well-being. A lack of accelerations can be concerning and may suggest fetal distress or potential hypoxia. Possible interpretations include reactive NSD, presence of at least 2 accelerations of fetal heart rate, FHR, of 15 beats per minute, BPM, for 15 seconds within a 20-minute window. Non-reactive NSD, absence of accelerations, which requires further investigation. If a non-reactive NST is identified, the healthcare provider should perform a biophysical profile, BPP. This evaluates fetal well-being using ultrasound and NST. Consider further evaluation, such as a contraction stress test, CST, or fetal scalp sampling, depending on the clinical scenario. Monitor the patient. Close observation for any signs of fetal distress or other complications. Relevant guidelines from the American College of Obstetricians and Gynecologists, ACOG, suggest that further testing should be initiated to ensure fetal well-being if NST results are non-reactive. MS. Thompson is a 28-year-old pregnant woman who is concerned about genetic testing options after learning she is at an increased risk for chromosomal abnormalities due to her age. What types of genetic testing should be discussed with her, and what key points should be included in the counseling process? Answer: in MS Thompson's case, 2 primary types of genetic testing should be considered. Chorionic villus sampling, CVS, typically performed between 10 and 13 weeks gestation. This test involves taking a sample of the placental tissue to test for chromosomal abnormalities. Amniocentesis, usually conducted between 15 and 20 weeks gestation. This involves withdrawing amniotic fluid to analyze fetal cells for genetic conditions. Key counseling points include Benefits and risks. Discuss the diagnostic accuracy, potential risks, e.g., miscarriage, and the implications of results, positive or negative. Informed consent. Ensure Ms. Thompson understands the procedures, including potential complications and the implications of test outcomes on her pregnancy. Emotional support. Address any concerns or anxieties related to testing outcomes and provide resources for support. Guidelines by ACOG emphasize informed decision-making in genetic testing, ensuring that patients understand their options and the associated risks. Mr. and Mrs. Smith are expecting their first child, but Mrs. Smith has a history of chronic hypertension. What should the healthcare team consider when managing her pregnancy, particularly regarding her medication and monitoring? Answer. In managing a pregnant patient with chronic hypertension, several considerations are crucial. Medication review. Assess the safety of current antihypertensive medications. Some, like ACE inhibitors, are contraindicated during pregnancy. Safe alternatives include labetalol or methyl-dopa. Monitoring. Regular monitoring of blood pressure, fetal growth, and maternal health is essential. A multidisciplinary approach may involve obstetricians, cardiologists, and primary care providers. Patient education. Inform Mrs. Smith about recognizing signs of hypertensive disorders of pregnancy, such as preeclampsia, which can develop in women with pre-existing hypertension. Lifestyle modifications. Advise on lifestyle changes that may help manage hypertension, such as diet, e.g., low sodium, regular exercise as tolerated, and stress management techniques. Relevant guidelines from ACOG highlight the importance of individualized care and ongoing monitoring for women with chronic conditions during pregnancy. Take a scenario where a pregnant woman is diagnosed with severe fetal anomalies that are incompatible with life. What ethical considerations should the healthcare team address in terms of patient autonomy and informed consent? Answer. The following ethical considerations are paramount. Informed consent. The healthcare team must ensure that the patient understands the diagnosis, prognosis, and available options, including the possibility of continuing or terminating the pregnancy. Patient autonomy. Respecting the patient's wishes is critical. The team should facilitate discussions that honor the patient's values and beliefs, even if they conflict with medical recommendations. Multidisciplinary approach, involving a team that includes obstetricians, genetic counselors, and social workers, can provide comprehensive support and address the patient's emotional and psychological needs. Legal considerations. It is vital to be aware of state laws regarding termination of pregnancy, especially in cases of fetal anomalies. ACOG emphasizes the importance of balancing ethical principles with clinical guidelines to support informed patient decision-making in complex scenarios. Describe the techniques utilized in intrauterine fetal monitoring. What are the indications for using these techniques, and what data should be collected during monitoring? Answer. Intrauterine fetal monitoring can be conducted via two main techniques. External fetal monitoring. This involves placing transducers on the maternal abdomen to monitor fetal heart rate, FHR, and uterine contractions. Indications. Used in routine labor assessments and when there are concerns about fetal well-being. Data collected. Continuous monitoring of FHR patterns, variability, and the frequency and duration of contractions. Internal fetal monitoring. This involves placing a fetal scalp electrode directly on the fetal scalp for more accurate FHR readings. Indications. Indicated in high-risk pregnancies or when external monitoring is inadequate. Data collected. More precise FHR patterns and the ability to monitor in cases of significant maternal movement. The COG guidelines recommend that fetal monitoring should be individualized based on the clinical situation, with a focus on interpreting FHR patterns to assess fetal well-being. A pregnant woman with pre-existing renal disease presents for her first prenatal visit. What specific management strategies should the healthcare provider implement to ensure her health and that of her fetus? Answer. Management strategies for a pregnant patient with renal disease should include medication adjustments. Review and adjust medications to ensure they are safe during pregnancy. Many renal medications may require alteration or discontinuation. Regular monitoring. Schedule frequent prenatal visits to monitor renal function, e.g., serum creatinine levels, blood pressure, and proteinuria. Consultations. Involve a nephrologist in her care for comprehensive management of her renal condition and potential pregnancy complications. Nutritional guidance. Provide dietary counseling to ensure optimal nutrition while managing fluid and electrolyte balance. Patient education. Educate the patient on signs of complications such as hypertension or preeclampsia. Guidelines from ACOG and the National Kidney Foundation emphasize the importance of a multidisciplinary approach to manage chronic renal conditions during pregnancy effectively. Explain the components of a biophysical profile (BPP) and how it is used to assess fetal health. What scores indicate the need for further intervention? Answer: a biophysical profile evaluates 5 key components. Fetal heart rate, assessment via NST. The score of 2 is assigned for a reactive NST and 0 for a non-reactive NST. Fetal breathing movements. At least one episode of fetal breathing lasting 30 seconds is scored as 2, otherwise it scores 0. Fetal movements. At least 3 discrete body or limb movements in 30 minutes earns a score of 2, fewer than 3 scores 0. Fetal tone. One episode of active extension and return to flexion scores 2, absence of this scores 0. Amniotic fluid volume. A single vertical pocket of fluid greater than 2 centimeters is scored as 2, less than this scores 0. The total score can range from 0 to 10. A score of 8, 1 is generally reassuring, while a score of 6 suggests further evaluation, such as a CST or repeat PPP, and a score of 0, 4 may indicate immediate intervention due to potential fetal distress. Mrs. Garcia, a 35-year-old woman, is diagnosed with gestational diabetes. During her follow-up visit, she expresses uncertainty about managing her condition and the implications for her baby. What ethical considerations should the healthcare provider address in their counseling? Answer: the healthcare provider should address the following ethical considerations: informed consent, ensure that Mrs. Garcia understands her diagnosis, the risks associated with gestational diabetes, and the importance of adhering to a treatment plan. Autonomy and empowerment, encourage Mrs. Garcia to actively participate in her care decisions, helping her feel empowered and informed about managing her condition. Cultural sensitivity, be aware of Mrs. Garcia's cultural background and how it may impact her understanding of gestational diabetes and her approach to treatment. Support resources. Provide information about dietary counseling, support groups, and education classes to help her manage her condition effectively. ACOG emphasizes the need for clear communication and respect for patient autonomy in making informed choices regarding their healthcare. A fetal heart rate tracing shows decelerations with a characteristic V shape during contractions. How should the healthcare provider interpret this finding, and what actions are warranted based on this pattern? Answer: the V-shaped decelerations are indicative of variable decelerations, often caused by umbilical cord compression. The interpretation includes moderate variable decelerations, typically associated with mild or moderate fetal distress but may resolve with repositioning of the mother. Severe variable decelerations can indicate significant fetal compromise requiring immediate intervention. Actions warranted include maternal position change. Encourage the mother to change positions to relieve pressure on the umbilical cord. Monitoring. Continuous monitoring of fetal heart rate and uterine contractions is essential. Consideration of further interventions. If decelerations persist or worsen, prepare for potential interventions, including amnioinfusion or cesarean delivery if fetal distress is confirmed. Guidelines from ACOG recommend timely assessment and intervention in cases of concerning fetal heart rate patterns to ensure fetal well-being. A pregnant patient with a history of preeclampsia presents at 28 weeks gestation with elevated blood pressure readings. What factors should be assessed to determine her risk and management plan? Answer: to assess the risk and management plan for a patient with a history of preeclampsia, the healthcare provider should consider blood pressure monitoring, regular and consistent monitoring of blood pressure readings to detect any escalating trends, symptoms of severe preeclampsia, evaluate for signs such as severe headache, visual changes, epigastric pain, or swelling that may indicate worsening conditions, laboratory tests, conduct tests for proteinuria, and assess liver and renal function to evaluate organ involvement. Fetal monitoring. Implement fetal monitoring to assess fetal well-being, including ultrasound evaluations of fetal growth and amniotic fluid levels. Multidisciplinary approach. Collaborate with specialists, e.g. maternal fetal medicine, to create a tailored management plan that may involve medication, e.g. antihypertensives, and close surveillance. Guidelines from ACOG emphasize early identification and intervention in managing preeclampsia to optimize maternal and fetal outcomes. What are the primary risk factors associated with developing cervical cancer, and how do these factors influence screening recommendations? Answer: cervical cancer is predominantly caused by persistent infection with high-risk human papillomavirus (HPV) types, particularly HPV 16 and 18. Key risk factors include sexual activity. Early onset of sexual activity and multiple sexual partners increase the risk. HPV infection. A significant correlation exists between HPV infection and cervical cancer development. Immunosuppression, conditions such as HIV/AIDS or immunosuppressive therapy can enhance susceptibility. Smoking, tobacco use has been linked to an increased risk of cervical cancer. Screening recommendations. According to the U.S. Preventive Services Task Force (OSPF) and the American College of Obstetricians and Gynecologists (ECOG), screening with Pap smear should begin at age 21, regardless of sexual activity. From ages 30 to 65, women can opt for Pap alone every 3 years or Pap plus HPV testing every 5 years, which is more effective in detecting high-risk HPV and precancerous lesions. Explain the various types of urinary incontinence and the recommended behavioral treatment options for each. Answer: urinary incontinence (UI) can be categorized into several types. Stress incontinence. Leakage occurs during activities that increase abdominal pressure, e.g., coughing, sneezing. Urge incontinence. A sudden and intense urge to urinate leads to involuntary leakage. Overflow incontinence. The bladder overfills due to inability to empty fully, resulting in frequent dribbling. Behavioral treatment options. Stress incontinence. Pelvic floor muscle training, Kegel exercises to strengthen the pelvic support. Urge incontinence. Bladder training, where the patient gradually increases the time between voiding to improve bladder control. Overflow incontinence. Timed voiding schedules to minimize retention and promote bladder empty. Mr. Thompson is a 62-year-old patient presenting with a rectocele. He expresses concern about the impact of this condition on his quality of life. What are the non-surgical management strategies available for Mr. Thompson? Answer: for Mr. Thompson, non-surgical management options for rectocele may include pessaries. A pessary can be fitted to provide support and alleviate symptoms, allowing for improved bowel function. Pelvic floor physical therapy. Engaging in exercises to strengthen pelvic floor muscles may help reduce symptoms. Lifestyle modifications. Dietary changes to increase fiber intake can alleviate constipation, which may exacerbate rectocele symptoms. Education and counseling. Providing information about the condition and support can help manage anxiety and improve coping strategies. These non-surgical approaches are often first-line treatments, especially for those with mild to moderate symptoms or those who prefer to avoid surgical risks. What are the key elements involved in the diagnosis and staging of ovarian cancer? Answer: diagnosis of ovarian cancer typically involves history and physical examination, assessing symptoms like abdominal pain, bloating, and changes in bowel habits. Imaging studies, transvaginal ultrasound and CT scans help visualize the ovaries and detect masses. Tumor markers. Elevated levels of Ca-125 may indicate the presence of ovarian cancer but are not definitive. Staging. Ovarian cancer staging is primarily determined by the FIGO classification system, which includes Stage I, tumor confined to the ovaries. Stidome tumor involves one or both ovaries with pelvic extension. Stygome thoruma involves one or both ovaries with peritoneal implants outside the pelvis. Stid Romanid, distant metastases beyond the peritoneal cavity. Staging is crucial as it guides treatment decisions and prognostic evaluations. Discuss the role of chemotherapy in the treatment of endometrial cancer and the factors influencing treatment decisions. Answer: chemotherapy is generally indicated in the treatment of endometrial cancer, particularly in advanced stages, stage I by Anne Romana, to reduce tumor burden and control metastases. High-grade tumors. Adjuvant chemotherapy is often recommended to reduce recurrence risk. Factors influencing treatment decisions. Tumor characteristics, histologic type, grade and stage, patient factors, age, comorbidities and performance status, response to initial treatment. Evaluating the response to prior therapies may influence the choice of agents, e.g. paclitaxel and carboplatin. Guidelines from the National Comprehensive Cancer Network (SEN) support the integration of chemotherapy in specific scenarios based on the cancer's characteristics. Identify the indications for surgical intervention in pelvic organ prolapse and discuss the non-invasive treatment options available. Answer: indications for surgical intervention. Severe symptoms that significantly impair quality of life, including urinary or bowel dysfunction, failure of conservative management, recurrent prolapse after previous non-surgical treatment, non-invasive treatment options, pessaries used to support pelvic organs and alleviate symptoms, pelvic floor exercises, Kegel exercises to strengthen pelvic support, lifestyle changes, weight loss, managing chronic cough, and treating constipation can minimize symptoms. Each patient's case should be evaluated individually, taking into account symptom severity, desire for future pregnancies, and overall health status before proceeding to surgery. Ms. Johnson, a 55-year-old woman, presents for routine screening and expresses anxiety about her family history of ovarian cancer. What strategies should her healthcare provider implement to address her concerns and improve her screening outcomes? Answer. For Ms. Johnson, the healthcare provider should consider the following strategies: risk assessment, perform a detailed family history evaluation and consider genetic counseling for BRCA mutations, especially given her family history. Education, provide comprehensive information on the importance of screening and early detection of ovarian cancer. Screening options, discuss available options, including transvaginal ultrasound and Co-125 testing, along with their limitations. Support resources, recommend support groups or counseling services to address her anxiety and provide community support. Implementing a patient-centered approach will empower Ms. Johnson in her health decisions and alleviate her concerns regarding cancer risk. What are the surgical options available for patients diagnosed with cervical cancer, and how are they determined based on cancer staging? Answer. Surgical options for cervical cancer depend on the stage of the disease. Stage II, simple hysterectomy may be sufficient, as this stage involves only minimal invasion. Stage IB and IA, a radical hysterectomy, which includes removal of the cervix, uterus, and surrounding tissues, is commonly indicated. Stage IIB and beyond, chemoradiation is often the preferred treatment. However, for select patients, pelvic exenteration may be an option if there is no pelvic lymph node involvement. Guidelines from the American Joint Committee on Cancer (AJC) inform the staging and corresponding treatment pathways, emphasizing the importance of multidisciplinary evaluation in determining the most effective surgical approach. How does the management of urinary incontinence vary based on its classification, and what is the role of surgical interventions? Answer. Management of urinary incontinence differs based on classification. Stress incontinence, typically treated with pelvic floor muscle training initially. Surgical options include midurethral sling procedures and Birch-Kolber suspension. Urge incontinence, managed with bladder training and anticholinergic medications. Surgical options like sacral neuromodulation may be considered in refractory cases. Overflow incontinence focuses on bladder emptying techniques and, if necessary, surgical interventions such as prostate surgery in men or bladder augmentation. The choice of intervention is guided by factors including patient symptoms, comorbidities, and the impact on quality of life. Describe the implications of the FIGO classification system in the context of gynecologic oncology and its significance in treatment planning. Answer. The FIGO International Federation of Gynecology and Obstetrics classification system is crucial in gynecologic oncology as it standardizes staging, provides a universally recognized framework for staging various gynecological cancers, allowing for consistent treatment planning and prognostic evaluation, guides treatment decisions. Each stage correlates with specific treatment protocols. For instance, early-stage cancers may benefit from surgical intervention alone, while advanced stages may require multimodal approaches. Surgery, chemotherapy, radiation facilitates research and clinical trials. By utilizing a standardized classification, researchers can stratify patients accurately for clinical trials, thereby improving the reliability of study outcomes. In summary, the FIGO classification system plays a fundamental role in ensuring that patients receive appropriate, evidence-based care tailored to their specific stage of cancer.